Well, it gives me the greatest pleasure to introduce what is supposed to be one of the highlights, not the only highlight, but one of the highlights of this conference, of any IUSTI conference, is our debate. We've got an interesting topic for you and two very keen and enthusiastic and experienced speakers. I'm Peter Greenhouse, consultant in sexual health, ex-consultant in sexual health from Bristol, and I've done a lot of debating and also quite a bit of chairing for IUSTI over the years. And I've used this image, which is a reconstruction of the frieze from the front of the Parthenon, which is going to illustrate our debate. So the topic of discussion is: this House strongly supports the use of AI in sexual health care. Bearing in mind, you have to bear in mind every single word, weigh each word precisely when you're thinking about the vote for this. But I thought we would go back to our Athenian roots and think of perhaps one of the very first competitions or debates, if you like, contests that occurred on the Acropolis between Poseidon, the god of the sea, and Athena, the god of wisdom. And this is the competition for to become the deity, the patron deity of the city. And Poseidon produced a spring of salt water, not very useful actually, and Athena, much more wisely, produced the first olive tree, and she won the competition, and that gave the city its name of Athens. Now, that doesn't necessarily mean to say that Athena is going to win in this particular competition, but we have two exceptional opponents in this debate. First of all, for the motion will be Dr. Tom Nadarzynski, who's a reader in digital health psychology at the University of Westminster School of Social Sciences. He's published a lot on the subject of AI. Against the motion will be Professor Claudia Estcourt, who's Professor of Sexual Health and HIV at Glasgow University. She's also taken some activities in London as well. And she's also published very widely on certainly access to sexual health care in relation to digital issues. So I thought when we had a discussion about how we would go about this debate, they mentioned something about AI being a bit of a black box. And I wonder whether this is in fact Pandora's box, because everybody knows that Pandora, well, not everybody knows that Pandora was the first woman on Earth, created by Zeus as a punishment for Prometheus' use of the theft of fire from the gods. Now, she was given this box, and she was warned never to open it. Now, some of you have very little conception of AI. I think we have a little bit more from the work that was presented earlier on today, but still it remains a bit of a black box. She was told never to open it, but her curiosity got the better of her, and she opened the box, and opening the box was supposed to release all the evils into the world, and the only thing that remained in the box was hope. So I hope we can get some of this information and this misinformation or these concerns out to you in this debate, because this debate is to entertain and to educate and to inform in equal measure, and I've deliberately invited our contestants, if you like, to take the diametrically opposing views. Another thing that I thought we would talk about is what actually happened in the first session, one of the first sessions today, because several of these issues were discussed, such as the business of accessibility to sexual health services, also the accuracy of the information that was there, whether there was equity in access, whether the information made people feel safe, and another very interesting term, well, trust, or rather medical mistrust was the phrase that was used. And there were very interesting presentations on the accuracy of diagnostics for scabies, for warts, and for syphilis. So a very interesting discussion. So I thought I'd just to finish off with my little spiel, which is supposed to last only a couple of minutes, and I've now used up my time. We should go back, if you like, to the roots of AI, and I'm going to read you the Bletchley Declaration. Now, Bletchley Park was the place where the very first example of an artificial intelligent machine was used to decode or break the German Enigma code. And the Bletchley Declaration was a meeting held under the auspices of the British government for 30 different countries, to sign up to a declaration on artificial intelligence. And I'll read you what it actually said. Artificial intelligence has the potential to transform and enhance human well-being, peace and prosperity. To realise this, we affirm that for the good of all, AI should be designed, developed, deployed and used in a manner that is safe and in such a way as to be human-centric, trustworthy and responsible. So that was their initial ploy. But they were also concerned about the opportunities and risks that might occur. So it said that the AI could pose significant risks, and to that end we welcome relevant efforts to examine and address the potential impact of AI systems on human rights protection, transparency, explainability, fairness, accountability, regulation, safety, appropriate human oversight, privacy, ethics, bias mitigation and data protection. Well, with all that in mind, it's time for you to vote, to make your preliminary vote. You have a choice to vote for the motion, you have a choice to vote against the motion, but most importantly, if you're not really sure, you also have the option, which you won't be given at the end, to say that you don't actually know. So what I'd like you to do now is to go to your phones and make your vote, please. And we're going to give you 30 or 40 seconds to do this. I know many of you have got plenty of experience of doing this. You can just press straight away. For those who are fiddling about to get their phone, we'll just give you a few more moments and then see what actually comes up on screen. See if we've got people struggling to decide.
Question, Peter.
A question.
What happens if you've left your phone up in your room?
Are
you allowed to vote for it?
I'll tell you what, just hang on. Given that you're one of the most senior gentlemen here, I would take chairman's privilege and say, how would you vote? And also, so I need to remember that as to how you will vote at the end.
Thank you very much.
And your choice is?
Don't know.
Excellent, well that's even better. Thank you, Michael. Well, I think it's time now to show what the results are, the preliminary results. So can we go over to the slide technicians, please? They're just fiddling about with this. Now, actually, I'm not sure that this is not going to present on your phones, because most of your poll results in the past have shown up on the phones, but we're deliberately keeping this secret so that we can work it out and then just surprise you with the result. So, ready to go? 1 moment, okay. Well, while we're thinking about that, perhaps you could think about some of the questions that you might like to ask our speakers when we have our discussion. We've got a good 15 minutes for discussion, plenty of time to talk this through. The organisers have been very generous in giving us a whole hour for this debate. We probably won't need a whole hour, but the more you can fill it, the better. And I hope I've filled in time for our technicians to come up with the results. It's ready to go. So we've got 79% are for the motion, 3% against the motion, and 18%, well, 18% plus 1, don't know. 18% plus 1, so we can do the maths. Thank you, but that's great. Well, without further ado, it's now my great pleasure to invite Tom Nadarzynski to take the podium. Tom, the floor is yours.
Makes my work a bit easier, doesn't it? Because there is so much support already. Great, it's a privilege to be here, and as it's supposed to be a debate, I invite your voice really, because it's about us discussing how we all understand AI. But
Can you hear the back?
can you hear that? Yes? Yes, can you hear it? Perfect, sorry. So for those who said that no, that 3% of you, or the 18% of, I don't know, plus 1, I probably would like to tell you why you might not be in support of AI. So I wanted to get the question off the way. And there's this one study that we conducted a few years ago that you see the publication of, where we ask you, or clinicians like you, about the attitudes towards AI, and we identified around 40 different reasons why, and these are, you might not think that we need AI, you might not understand what AI is, you might be afraid that you might be replaced by AI, you don't know what research says, or you are scared about accuracy, safety, equity, and you don't know any guidelines. So probably in that case I don't have to specify a little bit the fact that we need AI urgently. STIs are going up, we are dealing with antimicrobial resistance, there's increased pressure on sexual health services, we have cuts to sexual health services, and also we are dealing with structural inequalities and healthcare barriers, that's to including discrimination, stigma, and everything that goes with it. And also we are dealing with a huge wave of digitalization since the pandemic, where we all were forced to do everything from home. So we need a lot. In terms of Pandora box, it's interesting. If you read Sigmund Freud, you realize that actually Sigmund Freud understood Pandora box as female's genitalia, and so that we should be scared of it somehow, opening it. But I think that when we talk about AI, we really should be thinking about Sigmund Freud, Pandora's box, but really, what is AI? What is intelligence? If I ask you, what is intelligence? Would you be able to tell me? No, it's kind of a bit of a vague term. So I think that rather than being scared of horrors, I think that AI is just a toolbox. It's just a tool. It's a software that looks at big, large data sets, does some calculations, complex statistics, and gives the input. It's to recognize the patterns that it sees in the data that we have. No AI tool is perfect, but some are good enough. And the AI is only as good as the data that we are able to put there. So what will take you hours, AI can probably do in minutes. So around the question about, are you going to be replaced by AI? I don't really think so. I think it's not machine versus man. It's really man with a machine. It's the human with the machine. And I think when you look at the capabilities of AI, it's really is able to look at the large data sets for which we really don't have time to really look for the risk factors and predict outbreaks. It's really to provide sort of communication about sexual health 24/7, conversationally, in the language that is used by the users, in their native language. It can now identify images and help us to book that appointment in. But what about the human abilities? I think that it's a bit of a philosophical discussion that when we think about AI, it tells us something about who we are as humans, to what extent we are different. And what we do very well as healthcare professionals is that we integrate the lived experiences with clinical judgment, and we look at the context of the individual. We offer empathy, and we're able to provide emotional support, which is so needed in sexual health. And last time I checked, ChatGPT couldn't do on-hands examination, so I don't think that is changing anytime soon, but it's about understanding the subtle behavioral cues and developing that caring relationship. And I think that with AI, we can do it better. So if you have a question about, well, so what does the research say? I'm putting a lot of screenshots in case you are interested. There's quite a lot of research that has been published already about it, and there are multiple meta-analysis and systematic reviews. And what we really know that chatbots, the kind of a conversational agents, can really offer a wide access to sexual health information that can be really translated in any language to the high quality. And increasingly, as you know, teenagers using those tools, they really like those tools. So I think we need to really catch up with the technology. We really need to understand how these tools are used by those who really need sexual health advice. And to what extent these tools are really effective and can bring a change. In terms of the evidence around supplementary advice and counseling, there has been many cases in which AI can help people manage their health, understand medication, understand where to go, destigmatize sexual health. So it's to tailor the information to the individual. What AI is doing very well, and there's quite a lot of evidence about it, is that it's able to identify people at risk of STI and HIV in order to be able to recommend whether they require screening, vaccination, or any other intervention. So those tools are really helpful for something that we don't have time to do in our daily tasks. I think it's also, there's a kind of a bit of a shift because we're now living in the digital world. And so AI can be used as a tool for spotting online trends. So for example, we can see whether there are any emergent topics on social media around outbreaks or specific uses of contraception in the world that people talk to. So imagine that it's like a big focus group that we have access to for millions of people, and we are able to understand the kind of a general discourse, and AI tools can really support that. I think this one is kind of a big one, because AI tools can help us discover proteins for vaccines or even discover antibiotics against the antimicrobial resistant STI strains, such as gonorrhea vaccine. I think this is the tool that can really supercharge our intelligence and allow us to do things that we haven't been able to do before. So these are kind of a big discoveries that might affect sexual health. What about recognition? Something that we do, right? And AI can be dispatched as a tool to really understand people, how they test for HIV, and whether they understand the results of the HIV test. And that kind of AI tools could be very useful to tell people what they see. Also, in terms of looking at the skin lesions, there's a very high accuracy for specific lesions such as mpox or herpes simplex in terms of sensitivity and specificity. And again, there are already multiple systematic reviews and meta-analysis published about it. So there's sort of emergent evidence that those tools are very helpful. You might have a question. Well, what about that equity? What about bias? So this is the kind of studies that we conducted at the University of Westminster, where we really tried to develop chatbot-assisted self-assessment. So it's a tool that asks people questions around sexual health and tells them why it asks those questions, and then gathers information to really prompt, to allow the behavior change, to tell people what they're supposed to do next, whether go to the clinic, call the clinic, request online sampling test, or just call the clinic, or maybe wait because it's too early. And what we found is that our tool that was designed specifically for those who don't access sexual health clinics, for those from ethnic minority groups, that it increased intentions for STI screening, increased the concern for those who really needed to be concerned, and also kind of improved the attitudes towards STI screening. So it's not really about convenience, it's about justice as well. And so what do we need? I must admit, I'm also a little bit hesitant around the use of AI in sexual health. And I understand that it's a really complex topic. And AI, it's not one thing. These are many tools. So we need more scientific evidence with diverse data sets. We need a better understanding of ethics and safety measures and ongoing evaluations and audit. But I think what we need the most in the kind of contextualization of AI, how will that work for you in one context? How that can be co-designed with you and with your patients or participants if you're doing research. So there are multiple layers that brings the complexity, and AI is not just one thing. There are many tools. If you're curious about different sort of guidelines, then obviously WHO and any other big organizations are really putting the agreements in place. How can we move on in healthcare with AI? How can you do it ethically and efficiently, and that we understand the unintended consequences? So I would like to kind of bring one quote here from WHO, that AI is already transforming technology for sexual and reproductive health if we were aware of the potential dangers, cautious about implementation, and recognize AI is a tool and not a solution. We have a great opportunity to make sexual and reproductive services and information more accessible to all. So, would you strongly support the use of AI in sexual health care? Well, looks like many of you do. My position is that I would cautiously support the use of AI in sexual care. And I will really be careful about the context, try to understand the context. And once we figure that out, we have the full support. So I think we should be very brave in supporting this new technology, but we also need the data that supports as those studies that I already showed. Thank you.
Thank you, Jonathan. Just put the next slide. Well, that was a very good start to our debate, and we now proceed with the case against from Claudia Estcourt, and I hope you give it similar attention and thought and enthusiasm. Claudia, the floor is yours.
Thank you, and good evening. Over the next 10 minutes or so, I am going to persuade you that current artificial intelligence solutions will worsen the sexual health of the population. As Tom has said, AI is a really exciting tool, and it's implicitly neutral. But whether AI confirms benefits or harms is really up to us. And I believe that we are at the moment being driven by the technology, whereas I think we should be driving the AI. And I'm going to show you that the unintended consequences of AI, some of which are shown here and I'll explore in the next few slides, will impact most on the vulnerable and the marginalised. And I would really say to you what you already know, that in our field of massive health inequalities that we strive to minimise, it's currently just not ethical to take that risk. And quite simply, we are running before we can walk. And the very real limitations, the implementation challenges, the ethical considerations, patient safety risks, and regulatory hurdles are preventing many of the enticing benefits that my colleague has mentioned from actually being realised. So first of all, we must consider who in society has the poorest sexual health. So these are the people we must strive to reach. And quite simply, communities facing the greatest deprivation, however, have the least access to emerging technology. These are the inconvenient truths. STIs, HIV, bloodborne viruses are disproportionately affecting the most marginalised. And we know that marginalised people face huge barriers to accessing healthcare. And most inconveniently for us in the world of AI is that marginalised people have the lowest levels of digital and health literacy. We cannot take our eye off the ball. We've got to be prioritising throughout every AI tool we consider the needs of the most vulnerable. So, the inconvenient truth. We already know that game-changing interventions in our field, such as PrEP and online sexual healthcare provision, are not uptaken equally, and they follow a social gradient. So the consequences of blindly introducing AI-powered tech without proper evaluation frameworks and a really deep understanding of the pros and cons and the limitations will fantastically improve care for the well-educated, digitally literate in society. They will almost certainly currently lead to those most underserved being disproportionately disadvantaged, and lo and behold, health inequity will increase, and the overall population sexual health outcomes will worsen. And I just want you to remember this quote from Jessica Morley, who's a postdoctoral fellow at MIT. The greatest risk is that AI efficiency gains come at the price of equity. This is the most important slide in my presentation. This is about bias and discrimination in current AI tools. I'm saying if, and that's being generous. The data used in most existing AI models is unrepresentative of the population, so it is deeply biased, which means it will lead to misdiagnoses, poorer care, and barriers to care for minority groups. As a simple example, many AI models use electronic patient record data. EPR data is not representative of the whole population because it assumes everybody accesses care equally. We know that some groups use healthcare less and already have worse healthcare outcomes. And I'm going to explore this with you with the issue of skin cancer in people of colour. So, publicly available skin image datasets are used to assist AI-powered skin cancer diagnostics. This sounds fantastic. You might assume that the data feeding the AI tools are representative of the whole population, of the population that I care for, the population that you care for, that we all care for in different countries and regions. But what if they are not? This excellent systematic review analysed about 2,500 photographs from multiple datasets used in AI-powered photo recognition software to assist skin cancer diagnosis. How many of those 2,500 images were from people with brown skin? 10. How many of those images were from a person with dark brown or black skin? 1. This, to me, was jaw-dropping. And this is something that we cannot introduce into services right now. Quite simply, this isn't fair. Let's look at AI systems as the gateway to healthcare. Obviously, those with poor digital and health literacy will not be able to get through those doorways. According to the WHO, 6% of Europe's adult population have no home internet. That's 13% here in Greece. People in the lowest socioeconomic groups are 3 times less likely to use the internet regularly compared with people in the highest socioeconomic groups. Nearly half the Europeans in this WHO survey have what they classify as inadequate or problematic health literacy. So digital exclusion is a compounder and is becoming inextricably linked to low health literacy, and AI models will worsen that. So, what about the impact on us clinicians? Well, I'd just say beware false promises. So we've all heard this, the AI promise. Spend less time on your admin and more time with each patient, and the saved time can be spent with the patients that you're caring for. However, the reality in our over-demanded sexual healthcare services is that the saved time will be taken up seeing more new patients, which on one hand is fantastic, but that will lead to greater burnout and dissatisfaction. So what does that really mean? Well, I quite enjoy my cup of English tea when I'm signing off letters digitally, because it allows me a few minutes of my day when I'm busy in clinic not to have to think too much. So AI will remove that low intensity buffer activity, replacing it with a greater proportion of my time spent in higher intensity patient-facing work. Across the multidisciplinary team, what that will mean is that people will be spending more time at the limit of our skill sets, which on paper sounds fantastic, but we are not machines. This is the highly challenging part of our workload. It's highly enjoyable, but it's really intense, and it will contribute to greater burnout. Just like ultra-processed food, AI's ultra-processed facts are addictive and they're harmful. We've all spent years developing our critical questioning skills. Immediate answers will cause us to de-skill. We will lose our critical questioning and problem-solving approach. Algorithms will tell junior staff what to do, strangling development of their critical skills. We will become dependent on the AI, and worst of all, we will stop spotting critical errors. We've mentioned Pandora's box. I'm now going to talk about the AI black box. I think we would all agree that we have a responsibility to understand the pros, cons, and limitations of any technology we use, any laboratory technology, any other technology within our services. We have clinical guidelines. Lots of people spend an inordinate amount of time perusing the literature, perusing the evidence, providing clinical guidance. Not all of it is class 1, but at least we know, because the guidelines tell us, when a particular recommendation is just a lot of us experts deciding on what the answer is. So what that means is that we can critically appraise the data on which those recommendations are built, and we can apply that to our population or know immediately if it's not relevant to our population. AI is the black box though, unexplained clinical decision-making algorithms churning out a recommendation for which we cannot assess the risks and benefits and what that means for the patient in front of us. And we need to be very careful that we as clinicians are not liable for any mistakes that those AI tools might make. So going back to the skin cancer example, if we use that technology, we really have to know that the predictive accuracy in people with brown and black skin will be considerably less than in people with white skin, because there were no pictures from black people included in the training data. If our service predominantly uses that AI tool for diagnosis, it's very clear to me where we are deepening inequalities and where the unfairness is lying. Let's think about implementation. It's not just about AI, it's about the whole system. Certainly in the UK, public healthcare services have a really bad track record in implementing technologies effectively. Poor implementation of new technology into an often, I would say definitely inefficient system adds to workload, causing duplication, unnecessary work, slowing down the whole system. But most importantly, we have to invest in non-AI options. We can't just say AI works for the majority and conveniently ignore those for whom AI is not applicable. So automation applied to an inefficient system will magnify the inefficiency. Data privacy and security, I think we need to keep a close eye on. AI systems need data, we've talked about that. They will probably scrape electronic patient records, and that's not a bad place to start with the caveats that I've already given to you. But we need to be really sure that the clinical data being extracted from our clinical records really is safe, because the risks of a data breach with identifiable sexual health data leaking out into the public domain will be very well known to many of you as something that we must strive to avoid. The potential for data breaches causing mistrust is huge. It's quite difficult to come back from a situation like that. So in conclusion, we, I think, have a proud history of advocating for the most vulnerable and the most marginalised. And I would say to you that on the brink of a healthcare revolution, which is likely to exclude the marginalised and increase health inequalities, currently it is neither safe nor ethical to support the use of AI in sexual health care. Thank you.
Well, thank you very much, Claudia. You've really, if you like, put the cat among the pigeons there, and that was a great defence of the motion and a great attack against the motion as well. And Tom, could you come and join us on the panel? And we're interested to get any questions, comments, brickbats, not abuse, of course, but let's see, where do you stand? Can you just introduce yourselves before you speak, please? Go ahead.
Yes, hi, I'm Claudia.
Of
I'm
course.
from the UK, and I'm a physician. I wanted to say, I thought you did a brilliant job, Tom, and it's not because of anything you did or didn't say, but I think Claudia has persuaded me and I've changed my mind. There's two main concerns, both of which you pointed out there. Obviously, AI is only as useful as what we put into it, and we know that what we collect data-wise now is racist, it's probably sexist, and you absolutely skew to higher socioeconomic groups. So the data that's going into AI, on which it's making decisions, will definitely be biased, and it's going to be really hard for us to introduce that, remove that bias. And then the second thing I would say, certainly in the UK, people tell us exactly as you said, oh, you're going to save so much time, you'll have this to do with it. Countless times, I've been a consultant for 20 years, 10 of those I've been a clinical lead. What happens is they take that money out of your budget because they've said, you're more efficient now, so that 3 hours a week you spend doing that task will now go out of the budget. And that always happens. And I'll just say, while you were talking, I asked ChatGPT for the balanced arguments that you were running through. And the thing that really stuck out was this. Augmentation often turns into automation when budgets are tight. And that's absolutely been my experience. And that automation removes person-centred care. So I thought you did a great job.
Claire, can I just ask you, because you haven't actually asked a question.
No, I don't have any questions.
Well, no, I just...
I agree with Claudia.
Well, fine. So, as the chairman, I must ask Tom to respond to that, please.
Well, I very much agree, really. What would I say is that if AI is biased and so is human, then what can we do in the first place to remove that bias? And how can we ensure that we have better data so that this technology can be used and the medicine can move on and bring some good health outcomes on a public health level? So I understand there's no perfect AI, but if you say that we have biased data, then there's a problem there too.
It totally is.
Yeah.
I mean, I would love to live in a world where we could imagine that there isn't biased data and that we all don't have biased decision making based on who's in front of us. We definitely do. And some people are aware of that and some people aren't. However, what tends to happen with technology is we trust it implicitly. And that is slightly different. And then my main point really is, they definitely say, oh, now you don't need to do this job, and they take the money away. We've seen this happen with all new technologies in the UK. The online testing has removed budgets from direct face-to-face centres, and that's meant that the most vulnerable have now worse access, whilst those that are more capable of managing their own healthcare actually have more convenient and better access. And that's not because we don't want online testing, but the budget got shifted. It didn't get added in.
Do you want to come back on that? Okay, right, well, let's have the next questioner who's just standing behind you, and then we'll take Claudia at the front. Just introduce. Hi.
My name is Jason Farrell from the Netherlands, Amsterdam. I have done voice-assisted audio for research purposes in the past, and I know that, but that's usually with closed-ended questions, straight-on questions. When you do consultations to assess people's risk and creating prevention plans, where you might need open-ended questions and then follow-up probing questions, I see extremely difficult to get a consultation around my sexual risk behaviors, speaking to a robot or an AI to really determine my risk behaviors and how to manage those risk behaviors. And a lot of ethical reasons, because as mentioned in one of the slides, a lot of people who engage in drug-using risk behaviors have low literacy levels of understanding and trust. It's going to be more difficult. Having someone sit down in front of a computer with headphones and answering questions, that's totally different than getting a consultation from an app looking at that, and they do face recognition, and they figure out and they ask all these questions. So I'm very concerned about the ethical reasons and how it can actually assess somebody's issues correctly.
Tom, do you want to come back on that? And then
Sure.
Claudia.
I think that it's a very valid point, and we need to understand ethics more, and ethics around AI. And these are the WH guidelines around ethics, and I think it's fair to say that the whole technology is developing, and what we knew a year ago is probably different because those models are changing and becoming safer. I don't think that AI is for everyone, but I think that there will be a group of people who probably wouldn't come to see clinicians, but they will maybe benefit from some sort of virtual consultation that will prompt them to go into the right path to seek healthcare. So I think that we can't assume that everyone will come to the clinic. And maybe there are people, some, who would benefit from that intimate conversation with the chatbot.
Claudia, do you want to come back on that?
Thanks. I'm worried that Tom and I might flip sides as we take some of these questions, but I think in the interests of education, it's important that we do so. AI is a tool, and I think what's really, really important is that in our services we use the right tool for the right population, for the right job. And my really big concerns is that we won't have the time to evaluate these tools, and that they will be inflicted upon us with no evaluation. So the best or worst kept secret is that Tom and I come from a very similar standing point, but we've taken quite polarised views. But I think what we both said was really important was that this session's about really everyone coming out of the room with something that they didn't know. So the example that you've given, clearly it is perfectly possible to have an AI tool that is beautifully crafted for a particular patient group or a user group for a particular purpose. And the issue is that the time and resources needed to do that is quite high, and that increasingly we're seeing that research isn't even paying for it. So these will be difficult to achieve the very good tools that they could be, and that is a risk for us because we will get substandard tools that will disproportionately disadvantage those who are not particularly eloquent or have good, very, very good verbal literacy, or from different groups.
Thank you.
Analyze and discuss the multitude of sexual risk behaviors people can engage in to be sensory overload for some of my colleagues, let alone an AI app, right? So, yeah.
Okay.
Some of the things I'm concerned about.
Thank you very much. I think we need to move on to Claudia for her question.
I'm Claudia from Austria, and I have to say I'm fond of AI. It has facilitated my life a lot when I use it for certain purposes. But on the other hand, I invite you all to visit our session from tomorrow, where we have clinical pictures with an AI twist. We put together really nice clinical pictures. We have challenged AI a lot, of course. We didn't put the obvious. And we found out that AI was really wrong in many cases and awfully wrong. And so if I think in our hands, as you said, we use it as a tool, and we can use it, we know how to use it. But if it is in the hands of the patients themselves, and that is what's happening. They take a picture from their genital area because they don't want to show it to the doctor, and they load it up into ChatGPT, and they get awfully wrong answers sometimes, and that's where they start off. So I have to admit, I was voting for the motion at the beginning, but now I think I have changed my mind as well.
Claudia, do you want to come back on that, or no? Tom?
No?
No? Okay, fine. It's behind you, Raj, to the gentleman in the middle there.
Hi, David from Scotland. Question for Tom mainly, but Claudia kind of picked up on this about evaluation. So many of these large language models have issues with great complexity, and there's a determinism issue. So you put a set of same inputs in 100 times, and you get 99 outputs, but then one different output, and you can't actually work out why that is, because the large language model is just so complicated with so many connections. So in terms of evaluation, you can't really evaluate some of these models. Is that good enough? Is the 99 times that you get the output that's okay, that's fine, because a clinician would also maybe make a good call 99% of the time? Or do we actually need to dig under the surface more with these models, which isn't really possible?
Tom?
I think it's possible to evaluate large language models, and there are many different ways to do it, and a lot of papers have been published on how to do it and how to approach it from many different angles. And yes, I wouldn't say that AI is perfect, and when you mention 1% might be imperfect, and I think that sometimes asking 100 people in the room for something very obvious might cause one person to say something different. So I think that my emphasis will be on how those tools are used in the first place, and how we can safeguard against malfunctions and harm, and that's extremely important. So I wouldn't necessarily reject AI tools because 1% might be incorrect. I'll probably think about how can we develop frameworks that ensures that this is managed somehow. So I think that, you know, I wouldn't necessarily, it's a very good point from Claudia during her presentations about potential over-reliance. And I think that there is a risk of over-relying on faulty technology. And until we figure that out, I really don't think we should go ahead. But equally, I don't think we should stop the progress of medicine because we yet need to, you know, understand how to really safeguard things where we know that there's a great potential in this technology.
Good. Do you want to?
I think Tom's covered that. Thank you.
Raj.
Claudia, I think I'm a little bit concerned that you've made much of the biases that we've built into the models. I mean, where there's been deep analysis of things like probation decisions and sentencing, it's been exposed that the human interaction generates all sorts of biases on top of that. And there may be biases within medicine already, like the terrible survival rates and mortality in lying infants across different races. Isn't the chance that we could use AI to disentangle the biases and make sure that we only use what is acceptable to modern society? So I'd say, doesn't it offer a great opportunity here?
I think it does offer a great opportunity, and you're absolutely right. And Claire touched on that as well. We all have biases. We know health services are biased, and we know there is racism, particularly within health services. The thing is, AI needs data, and the data that's currently feeding it is data that's so deeply flawed that we can't really go any further till we create more data that's not flawed data, because it includes a greater sample of people from groups who are currently underrepresented. So there are some techniques that you can use. So Tom, in some of the lovely work about hypothetical acceptability of chatbots when they're specifically designed for a particular population, is really important, but the time it takes to develop tools like that is longer than most services or most health commissioners feel is appropriate. So it is possible, but the data has to be there first, and it's also really important that it's done meticulously and then evaluated. Otherwise, we will compound existing issues, even though the tool itself could potentially help us find solutions.
What AI generates an algorithm where you can look to see where the weighting of the different elements is placed. And if you find that it's weighting too much on an unacceptable characteristic, you can just sort of ease that out of your algorithm.
Well, I think that's really important with the skin cancer diagnostic. If that was a tool that was put into your service as a dermatologist and that the information about the training data set was not provided to you, you would use that tool with what you thought was similar positive predictive value, negative predictive value in all of your patients. So if you have got the manual that says, this is a tool that's developed on a data set that is almost exclusively white skin, so the diagnostic accuracy of this for people who do not have white skin is significantly different. I think there is a problem with that, because you're providing a service in which you've got a tool which is fantastic for the people of white-skinned ethnicities, and what are you going to put in place for people who don't? But also, if you don't know that it's not very good for people who don't have white skin, you have a massive problem.
Tom, did you want to comment on that at all?
No? Okay. And a question in the middle. Oh, there's one other thing I'd like to ask you to declare. Has your question been generated by AI? Because I know that Claire actually, she admitted that her question had been partially generated by AI, so I'd like to know whether this comes from here or from the tablet that's in your hand.
No, it comes from here, from me.
Excellent. Go ahead.
A couple of questions.
Sorry, who are you, sir?
My name is Marco Tudona, and I'm from Sexual Clinic in Torino.
There you go.
I think that we should define the field of using AI maybe. I was quite worried hearing the people talking to chatbot that may be a way to destigmatize, because I think it may also be a way to stigmatize. I mean, who advocates AI? I'm worried about that because I see around an overwhelming wave of hate and discrimination and racism. So I'm worried because I'm asking myself, people accessing to AI will get information elaborated, but who gave the information to the AI? Are we sure that it will help destigmatizing and not stigmatizing? Another questions?
I tell you what, let's do that question. Let's take that question first. Will it stigmatise or destigmatise?
Well, what I presented were scientific papers, and actually the research shows that it has a tendency to destigmatize sexual health and to make it more accessible. I think that it's valid to have a concern that it can be stigmatizing, but I haven't seen any evidence yet that will show that.
Another question is, do you think we do really have a choice? I mean, I sometimes ask myself if AI will just arrive, it's here, it's an instrument, and probably it will make people save a lot of money, so we will have to deal with it. I'm asking myself if the question maybe is not if support or not AI, but how can we get ready to deal with AI? I mean, do you think we really have a choice in using or not AI?
I think that's a really good question, and I think there are ways in which we can use AI, and there are tools that we can lobby for, and we need to look at quality. So we do have a choice, because if I was in a service where I was asked to work with, for example, a diagnostic tool that was the skin cancer diagnostic tool, I would actually say, I feel deeply unhappy about this. I do not wish to use this tool because of the bias in the tool itself and because of what it means for people of colour attending my service. Now, that's from an ethical perspective. So I think we're actually poised at a place where we don't just accept things, we actually challenge with a view to implementing what is good and improving what is not good. So there are some excellent examples. Professor Fairley's at the back. The work done by his group is meticulous in looking at the sorts of material that their models are trained on, being very open, being very transparent, and that's exactly what we need. But we shouldn't be accepting substandard tools where we don't have the correct knowledge about how they've been developed, the sorts of training sets on which they've been used. And it's just the same. If somebody asked you, we have a new laboratory test, there's not much data on it, but it's actually quicker, it will change your life, and it's probably quite good for people with gonorrhea, you wouldn't use that. You would demand the data. And I think we're just saying that's exactly the same for any AI tool that we use.
Can I just add?
Yep.
One point here. I think it's important and it's a valid point. I think also there's an issue of AI literacy, is that many patients and clinicians don't really know how to use that tool effectively and safely. And I think that we might have good tools, but despite that, many of us might not know how to use them, and that can also be the problem. So I think that it's not only AI and the bias in AI, but also there's an issue of our confidence that we know how to use it, we know what to do, we know how to do it safely and effectively. And I think that until that's figured out, we're probably not going to progress. But I think we shouldn't be rejecting the tool because we don't know how to use it. And I think that it has to come from both ways, and hopefully we'll get there, and that's where we're heading.
Great. Sebastian, and there'll be one more question after you because we're coming up to time.
I'm Sebastian from FRCOG. I'm going to be the Luddite in the room today. I think we're talking about two very different things. The AI that the doctor is using to be assisted by it, and the AI that our patients are using back home behind their screens. And these are we're talking about very, very different things, and we're talking about them as if they were one and only thing. Everybody's heard about Dr. Google. I mean, we've all had problems with Dr. Google, and I'm afraid that Dr. Google is becoming even more powerful with AI, and this is becoming a problem between our patients and us. I mean, I can't can't count the moments now, but when I tell my patients that, for instance, eating fat stuff won't give him acne, I see their eyes raising to the ceiling, and obviously these people won't believe me. And this is happening more and more and more and more. And this is the AI that people are using. And this AI are these instruments that are actually designed by people whose ambition is to make a lot of money. These are poor AI instruments that roam the internet for any information they will find on the topic that being prompted to find. And I'm afraid that this is not going to help us at all. So I think when we start this debate, we need to be certain that we're talking about the same thing. I mean, being helped by an AI is no problem for me. I'm using it for ancillary tasks. When I do an online conference and I need to produce minutes of that conference, it's excellent. But I mean, in terms of treating my patients, it's rarely as good. And in terms of my patients and what they find on the internet and what they find with these instruments, and the way it collides with whatever information I could give them, is problematic. And one little problem too, everybody hates boarding a plane these days because they're afraid they're going to aggravate the climate change. And nobody questions that by AI. And apparently there's a considerable amount of greenhouse gas things that are produced by AI. And I think we should reflect on this because nobody's ashamed to go on ChatGPT, and apparently it's just about the same as boarding a plane, so maybe we should reflect on that too.
Thank you, Sebastian. Do you want to come back on that, or do we leave that as a statement?
I think this, yeah, you can leave it.
Okay.
I think I was going to repeat some of the same things. It's a very broad motion, isn't it? Personally, I love AI for those kind of tasks that you described. You know, I've got 5 minutes before I go on holiday, and I've got to write up the minutes of this meeting and the summary of this meeting, and I dictate it, and there it is, just like that. I feel very happy to go on holiday with my jobs done. But the other point that Claudia mentioned is within our services, we did have an opportunity to use HIDI, which is an NHS approved dictation app, which some GPs were already using. But the point that Claudia made is about evaluating. So to be able to use my license for HIDI, I had to count how many minutes I was spending on admin. I don't have time to do that, so I haven't done that bit, so I haven't been able to use the HIDI because I'm not doing the evaluation phase before I get to use it. So that data isn't coming from me in terms of the research, I'm afraid, but maybe I should try harder.
Thank you very much. Well, I think we need to have our closing statements. So let's go over to Tom for just a few thoughts at the end of our debate.
So in general, I think that looking at the rates of STIs and that they are increasing, I think we probably understand that the old ways of doing things are not really working. And perhaps thinking about patients and those who suffer from sexually transmitted infections around the world, if we have access to those new tools, then I think we should. We are in Athens, and think about how medicine looked like here 2,000 years ago. And medicine doesn't stop, it sort of moves on. And so we have access to those new tools, and I believe that we need to really figure out how to use those tools that they benefit us. But we shouldn't oppose them. I think that we should support them. It's a matter of just having the right time and the right evaluation and the right support.
Thank you. Claudia, your response.
Thank you. And I'm just going to talk to the people who are wavering, but also these are lessons for all of us. What I would say is, first of all, we do no harm. And I've talked about the harms and the potential harms of AI. So before we introduce any AI tool, there's a plethora of which have been amply described by Tom. I think there are 8 criteria that we need to ask ourselves as individual clinicians, particularly I think it's interesting for service users as well, and also for people commissioning services. And these are distilled from WHO recommendations and the British Medical Association. So do we really know whether the AI has been robustly assessed for safety and efficacy in clinical settings? Could underserved patients be disadvantaged by the AI itself or the wider implications of implementation? What are the robust, hopefully, government systems in place to ensure patient safety? Importantly, have clinicians and service users been involved in the development of the AI, or has it just come from a tech company? Can patients opt out? This is a really important criteria that's stated in both WHO and BMA guidance. How will the AI tool integrate within our services? Will it make our services less efficient? Will it slow things down? Will it deprioritize some populations? Does our IT structure, is it capable of supporting the AI tool? And do you really know who is liable if something goes wrong? Because it could be you or it could be me. So I'd just really like to end by showing you these two really important quotations, one from WHO and one from the World Economic Forum, and really reiterate the quote I gave you at the start, which is that the greatest risk is that AI gains come at the price of equity, and ask you if that is the price that you are currently willing to pay. Thank you.
Well, thank you very much indeed to both of our opponents and proponents. And it's now your turn to choose. This is, if you like, the synthesis of the argument and the denouement of our argument. So can we go to the poll, please? And let's see what people have to say. And we'll give you 30 seconds to...
Can we move our hands, though?
Wait a minute. Just let's have every... Michael, you get the prerogative of giving the final vote, but I would like to see everybody else use their phones and make the vote before you can cast yours. So if you'd like to vote now, and while you're thinking of voting, I'd liked a few of the issues that were brought up. I particularly liked Claudia's analogy of the ultra-processed facts. That was actually very important and very near to my heart, because I'm supposed to be on a diet and I never really know whether I'm doing it properly. Another few things that came up was Sebastian's point about the right tool being used, and different tools for different people, and Dr. Google as being perhaps the enemy. Also, Raj brought up a very good point about the possibility of disentangling the human biases that we all have in our everyday practice. And Tom's major point, I think, about the opportunities that AI offers, such as the pressure that we're under to deal with more and more and more STIs. Well, hopefully you've all had time to vote. So can we close the vote now? And I know that our technicians are going to take a little bit longer before the vote appears on the screen. So I've got a rabbit for a couple of seconds without hesitation, deviation or repetition.
It's like Eurovision.
What?
It's like Eurovision.
It's like Eurovision, okay.
We also need Michael's vote before.
Oh, yes, sorry. Thank you very much. Now that you've finished your vote, Michael, would you like to stand up and cast your vote? Can you stand up and cast your vote? No, into the microphone.
My vote is to follow the argument of Claudia, and it is against.
Okay, well, we'll have a discussion about that afterwards. I think actually one of the things that's been most brilliant about this debate is that we've dealt with a lot of new information and new concepts and new ideas about AI. And I think we're all a lot wiser after the debate, whether we know which way to vote. I am deliberately not casting my vote because I'm supposed to be unbiased. Now, we are ready for the vote. And I think we can comprehensively say that I don't think, to be honest, I don't think I've ever seen a vote change to that extent. So I think we have to congratulate Claudia with a quite brilliant defence. However, I would also say that Tom actually, I had to work very hard to persuade Tom to be here because I knew he was the best person to put the case because he's done the research. And he actually got in at 4 o'clock in the morning, largely at my behest. I'd even offered him a spare bed in my flat if he needed one, but luckily he had other things to do. So Tom, thank you very much. Can we just go to the next slide and just the final slide? Thank you very much.
It's been a delight. And so my final question for you is, are you ready to open Pandora's box, or perhaps even Schrodinger's box? I also want to thank the organisers for inviting us. Ευχαριστώ πολύ και καλησπέρα. That was lovely, really good. Oh, by the way, one more thing. Quick wave to the quick wave to the camera so we can get a picture. That's great. Okay, all done.
Thank you.
And that's a wrap.